Hello, everyone. Good morning. Today is Tuesday, March 9, 2021, and it is 9 a.m. Eastern Standard Time. And this is the start of our program for virtual online ART training. Today, we are going to cover Module 2, Advanced Andrology Technique. My name is Ashok Agarwal. I am the director of the Andrology Center. I welcome you all to this program. We are very, very pleased to have you join us. And let me begin by my introduction. Okay, so I'm going to be your host for the next 2.5 hours. So let us begin. This is a brief biography about myself, and without taking too much time, I'm in charge of the Andrology Center here at the Cleveland Clinic and have been there for many years. I'm also the director of the American Center for Reproductive Medicine. I staff in the Department of Urology. We are very proud as a group. Our program is recognized as #1 in terms of the number of publications, the quality of publication, and the reach of our publications in the field of male infertility, andrology, and human-assisted reproduction. We have a very large number of medical textbooks that have been published, and we are very proud that very large number of clinicians, researchers, students have received training in our program from more than 100 countries over the last several years. I want to declare that the organizers and speakers of this program have no conflict of interest. We have not contacted any companies or outside entities for sponsorship. The program that we offer is entirely made possible by support from our center. Webcasting is supported by David Reichling and David Wolfley from the Information Technology Division of the Cleveland Clinic. Thank you to both of them. Further, the course faculty have donated their time for this online training. The program coordinators have volunteered their time for this training course. The names, images, and description of certain products or instruments shown or discussed during our presentations are being used routinely in our Andrology Center. These items are not endorsed by the speakers. Now, let's talk about what we are going to be doing today. So today we are going to be teaching and training you in advanced andrology techniques. And the techniques that we are going to cover, we are going to start by discussing what is advanced sperm function test. Then we are going to go to the most important test, which is currently being employed, is called sperm DNA fragmentation test. We'll also cover test for oxidative stress as oxidation reduction potential test. Then we are going to talk about the lab developed test for sperm DNA fragmentation, and then cover the clinical relevance of sperm DNA fragmentation in human assisted reproduction. And lastly, there will be a talk by our clinician on the clinical interpretation of everything that we are going to be covering here. So these are, again, the topics from starting in a clockwise manner, a laboratory evaluation, clinical relevance, evaluation of SDF, and lastly, clinical interpretation of laboratory tests, laboratory results that you will receive, and how to make sense of it. And this is the program in a on the left side, and our speakers for the day here. Our speakers are Professor Ralph Henkel, Dr. Sejal Gupta, Dr. Renata, Dr. Rakesh Sharma, and Dr. Neel Parekh. So today we are going to be talking about the advanced andrology techniques. On the left side of the panel, you see the basic test, which can be covered under the semen analysis and many of the ancillary tests that you heard last in the month of January during module 1. So these are basic tests. And then we are talking about the advanced andrology test. And there are a variety of tests. This panel has just a small number of tests, which we have illustrated here. And many of them, or some of them, will be highlighted in today's talk. So why we chose the test for oxidative stress? And the reason is that there is such a large amount of information on the role of oxidative stress in male reproduction and male fertility. Right from the very beginning, from 1940 to current, there are thousands, almost close to 1,200 publications, which is probably the largest number of publications in one subject matter. So it is a very important area, and we felt that it is important for us to cover that. And also we, on the right side, you can see we have a great deal of expertise in this particular area, and we feel that we can do a very good job in talking about and explaining the practical side of these tests for male infertility. And then the sperm DNA fragmentation, another important test. So if you look at the left side, again, this is a very hot area with very large number of publications, both original publication reviews and meta-analysis. And this data is only until 2019, and certainly the number have increased since then. And on the right side, again, we have at the Cleveland Clinic a great deal of expertise in this area, not only from a research point of view, but also from a clinical point of view. We have developed techniques, we have standardized those techniques for sperm DNA fragmentation testing, and we felt that we can share these things with a great deal of expertise and confidence. Neel is a staff in the Department of Urology at Cleveland Clinic. He has done a fellowship in a clinical fellowship in andrology and male infertility, and was trained here recently before he went on to the staff position about more than a year ago. He has a lot of good experience in all aspects of male infertility, as you can see. More importantly, Neel has been part of the lectures, the online training program that we are hosting for the last 4 months, and he has helped us put all the laboratory related questions in terms of the clinical interpretation and what should be the clinical management of patients as a result of the test results that we see. So Neel is going to begin his presentation today. Neel today is his surgery day. Always Tuesday is his surgery day. So he has kindly recorded his presentation, a wonderful presentation based on the questions that we had provided to him, and you will really enjoy it. So I welcome Neel to begin his presentation, or we play his recorded presentation here now.
Clinical Assistant Professor in the Department of Urology at the Cleveland Clinic. By now, you should have just heard Dr. Finelli discuss the implications of sperm DNA fragmentation on assisted reproductive techniques. I'm going to segue into the clinical interpretation of these advanced sperm tests in my clinical practice in male infertility. We'll discuss a series of clinical questions as we've done before. We'll start with question number 1. A patient presents with primary infertility. This is his following semen analysis: a somewhat low sperm concentration at 12 million per milliliter, normal motility at 50%, a morphology of 6%, and an elevated oxidative reductive potential at 6.5 millivolts. how will we manage this patient? Now, this is a fairly common patient presentation. This patient has oligozoospermia and elevated ORP. And as you have already learned in previous lectures, this is abnormal. Just as we do in any workup of a male infertile patient, we begin with a thorough history and physical examination, as well as obtaining a social history, which includes everything from smoking history, obesity, drug use, etc. You want to identify any possible causes of the abnormal semen parameters, as well as elevated ORP. This can include varicoceles, infection or inflammation, retrograde ejaculation, cancer, a history of undescended testicle, testicular surgeries, hormonal imbalances, genetic mutations, pelvic surgeries, or potentially medication or radiation therapy. Now, up to 50% of patients, we do not quite know the etiology of male infertility. These patients are subsequently classified as having idiopathic male infertility. This is defined as the presence of altered semen characteristics without an identifiable cause and the absence of female factor infertility. However, and as we can see in this clinical situation, 30 to 80% of infertile men may also have concomitant elevated ROS levels. Elevated ROS levels are a potentially treatable condition, and this is discussed in our paper published last year called Male Oxidative Stress Infertility, the Proposed Terminology and Clinical Practice Guidelines for the Management of Idiopathic Male Infertility. So it is important, and I cannot stress enough, that male reproductive potential cannot be adequately assessed if seminal oxidative stress is overlooked. Unfortunately, there is no consensus on how to adequately measure oxidative stress or a diagnostic terminology until we published this paper on male oxidative stress infertility, or MOSI. So in this situation, this patient has abnormal semen parameters, but no identifiable cause of the abnormal semen parameters, and in addition has elevated oxidative stress, and which is indicated by his elevated ORP. So we start here with a basic semen analysis, followed by evaluation of oxidative stress through ORP. And if elevated, we want to begin by ruling out any clinical cause of the elevated OS, whether this is an infection, lifestyle issues such as smoking and obesity, or a clinical condition such as a varicocele. However, in a patient that does not have any reversible causes, but also has elevated oxidative stress, these patients are determined to have male oxidative stress infertility, or MOSI. Unfortunately, there are no evidence-based treatment guidelines available for the treatment of idiopathic male infertility. But we believe by identifying these men with MOSI, we can identify which group or which subset of patients would benefit from antioxidant therapy. So we know there are different types of empirical medical therapy, as I've discussed in my previous lectures, both hormonal and non-hormonal. Hormonal medication can be used off-label, which means not FDA approved in the United States, for the treatment of male infertility. However, the data on its efficacy is lacking. We do know many men are prescribed antioxidants regardless of their oxidative stress status. So many of these men who may not even require antioxidants may actually be being harmed by the overuse or overprescription of antioxidants, because we know that reductive stress, which is the opposite of oxidative stress, can have a negative impact of semen parameters. So we believe it is very important to identify these men specifically with elevated oxidative stress, and those men should be the ones targeted with antioxidant supplementation. We typically recommend a course of 3 months, and this is followed by retesting of oxidative stress with ORP after those 3 months. Clinical question number 2. A patient presents with primary infertility. He has an asymptomatic grade 2 left varicocele, and a semen analysis at an outside facility shows the following: normal semen volume of 2.5 mLs, a sperm concentration of 22 million per milliliter, a motility of 40%, and a morphology of 6%. How will you manage this patient? So in essence, this patient has normal semen parameters and a grade 2 left varicocele. If you remember, we grade varicoceles grade 1 through 3, and we typically only recommend fixing grade 2 and grade 3. But before we discuss any options, we want to complete the male fertility evaluation, assess the female factor, ensure that the couple is performing intercourse appropriately, timing it, not using any spermatotoxic lubricants, etc. If this patient were in my office, he has only had one prior semen analysis, which was normal, and an asymptomatic varicocele, I would recommend a repeat semen analysis and offer him advanced sperm functional testing. As you know, that the guidelines recommend 2 semen analyses spaced by approximately 2 to 4 weeks apart. And in this situation, the advanced sperm functional testing can give us more information before we decide to fix a varicocele. So here we have our treatment algorithm in this particular patient. His repeat semen analysis is here and shows a normal volume, a normal concentration, a normal motility at 42%, as well as morphology at 6%, but his sperm DNA fragmentation measured via tunnel is elevated at 26%. So after the evaluation of the infertile couple, we have identified a varicocele. Now, varicocelectomy is a treatment option in this patient with elevated SDF but normal semen parameters. The American Urological Association and the American Society of Reproductive Medicine also believes that varicocele treatment should be offered to the male partner of a couple attempting to conceive when all of the following is present: a palpable varicocele, which is considered a grade 2 or grade 3. A couple has documented infertility. The female has normal fertility or potentially correctable infertility, and one or more abnormal semen parameters or sperm function test results. So in this situation, while his semen parameters are normal, he does have elevated SDF. While the association between SDF and high-grade varicocele is much stronger, patients with low-grade varicocele also have shown an improvement in natural pregnancy rate that is similar to those with high-grade varicocele after surgery. Moving on to question number 3. We have a 28-year-old gentleman who presents with primary infertility for the last 3 years. There is no identifiable female factor. However, the couple has undergone 3 intrauterine insemination cycles without success. Here is his semen analysis. He has a low semen concentration at 9.8 million per milliliter, a reduced motility at 28%, elevated ROS levels, an elevated ORP, and an elevated sperm DNA fragmentation by tunnel at 36%. How will you manage this couple? So a number of societies recommend an endocrinological evaluation in a patient with sperm concentration less than 10 million, or with men with impaired sexual function, or if you suspect an endocrinopathy. So in this patient, the minimum lab studies I would recommend is a testosterone and FSH. However, I also routinely include LH, estradiol, prolactin, their thyroid function, and hemoglobin A1C if there is a concern for diabetes. In this particular case, this patient has no lifestyle risk factors to explain his poor semen analysis. He is a non-smoker, he's not obese, etc. His hormone profile was normal, so ultimately he is determined to have oligoacenozoospermia with elevated reactive oxygen species, ORP, and SDF. Now they have failed IUI 3 times, and we would consider him to have the diagnosis of male oxidative stress infertility. Again, that is a patient with abnormal semen parameters without an identifiable cause and elevated SDF or oxidative stress, as we see in this case. And as I showed you on the previous algorithm, we would recommend treatment with 3 months of antioxidants and repeat the semen analysis with advanced sperm testing at that point. Now, unfortunately, in this patient's case, he really had no significant improvement in his sperm parameters after 3 months of antioxidant therapy. His oxidative stress levels also remained elevated. Now, it is very common in the United States that IVF or ICSI not be covered by insurance and is a significant out-of-pocket cost for many couples. I know there are many listeners across the world, and it may differ from country to country, and in fact it differs from state to state within the United States. In Ohio, it is very rare that we can get adequate coverage for fertility treatment. So this is not an uncommon scenario for us. This couple, while they cannot afford IVF ICSI, would like to potentially try in utero insemination again, which is significantly more affordable here than IVF is. I would counsel them on the fact that there is a negative impact on prolonged ejaculatory abstinence on sperm DNA fragmentation. We have seen that short-term recurrent ejaculation is a simple, non-invasive option to improve sperm DNA fragmentation. In addition to higher pregnancy rates in ICSI, recurrent ejaculation has been associated with significantly lower sperm DNA fragmentation. So for this patient, I typically recommend a regimen where they ejaculate daily for 1 week and then abstain for 2 days before repeating in utero insemination. Now, this recurrent ejaculation, in theory, should reduce his sperm DNA fragmentation, and with the addition of antioxidants, may provide some benefit on repeating IUI. So here on the algorithm, we can see that they have had recurrent IUI failure. However, ICSI is not feasible for them, whether it is for financial constraints or religious reasons in other scenarios. However, recurrent ejaculation, as circled here in red, is a recommended treatment approach to lower sperm DNA fragmentation. Moving on to our final clinical scenario. We have a couple with no identifiable female factor who is experiencing recurrent pregnancy loss after ICSI. The male partner has shown normal semen parameters, however, has an elevated SDF by tunnel of 60%. How will you manage this couple? So we know that the use of testicular sperm for ICSI is thought or theorized to bypass post-testicular chromatin damage caused by oxidative stress during sperm transit through the epididymis. And that is the reason some may offer testicular sperm for ICSI. However, before we elect to or recommend testicular sperm extraction in a non-azospermic patient, as in this situation, we have to know that intratesticular alterations in chromatin remodeling can also coexist, resulting in testicular retrieval of sperm with fragmented DNA. So before we were to offer testi-ICSI in a patient like this, first-line therapy should be adequate clinical management of their SDF. So once again, identifying any reversible cause of their sperm DNA fragmentation and potentially treating with antioxidants if possible. Now, there are a number of articles published on the use of testi-ICSI in non-azospermic men with high SDF. However, the majority of these studies are very small cohorts or case series without adequate control groups, and they do not report on live birth rates. Further complicating the situation is that SDF testing has not been validated for testicular sperm, making interpretation of testicular sperm DNA fragmentation levels difficult. And while some studies report a positive impact on assisted reproductive technique outcomes, using testicular sperm, the quality of the evidence is very weak. We also have to realize that we would be putting the patient typically under anesthesia for a surgical procedure that has potential risks. These risks include anesthesia, bleeding from a hematoma, infection. While these are all risks of a testicular sperm extraction procedure, proponents of TestDXC would argue that it is much less invasive than repeat oocyte retrieval in women. As of now, there is no consensus on the use of testicular-derived sperm for ICSI. So in this clinical situation, where the patient has normal semen parameters but elevated SDF, we would begin with first-line treatment, which is either antioxidants or identifying or counseling on reversible risk factors before we offer TestDXC. So we have gone over several clinical scenarios that I see on a routine basis in our male infertility clinic. I hope this has been beneficial for all of the listeners. And overall, the take-home messages of the lecture today include the fact that sperm DNA integrity is crucial for fertilization and the development of healthy offspring. And there are a number of scenarios which can lead to this, which include men with idiopathic infertility or unexplained male infertility, recurrent pregnancy loss, clinical varicocele, IUI or IVF failure, and modifiable risk factors should all undergo sperm DNA fragment testing. We do have a few treatment options that are available to us at this time. This includes recurrent ejaculation, antioxidant therapy, lifestyle modification, and varicocelectomy are all proven treatments in reducing SDF. We know that reducing SDF seems to translate into better reproductive outcomes, and we also know that there are significantly lower levels of SDF in the testicle compared to ejaculated sperm. However, we need more well-designed studies in order to make a definitive conclusion on the use of testicular-derived sperm in ICSI in non-azospermic male with ICSI failure. Thank you for listening. If there are any questions, do not hesitate to reach out. My email address is Parekh, P-A-R-E-K-H-N 3 @ccf.org. Thank you.
Lastly, you can connect with our center by sending a request, searching my name and Cleveland Clinic. And the benefit of connecting is that we are providing daily updates on our research activities. We provide free access to hundreds of research articles published by our center, by our scientists and researchers and our collaborators. You can also read the latest research which have been presented at important national and international meetings, reproductive meetings and urological meetings. Learn about virtual research opportunities that our center provides. Learn about our online ART training courses, and also the opportunities to collaborate with a team of ACRM researchers. So please consider joining on our LinkedIn.